Thank you. So, just a short welcome, as always, to all of you that have joined this afternoon's upper GI endoscopy session. Just a reminder that we are hosted by the Gastro Foundation, and that's in association with Project iEcho and the University of New Mexico. We hold these sessions weekly on a Wednesday. So try and keep your Wednesday afternoons open, and we will open the chat for questions. I'm going to share my screen, and then we can get going. Cheryl, if you can just confirm that you're seeing that.
Yes, I can. All good.
Thank you so much. Right, so welcome to today's talk again. I thought we'd chat about Barrett's specifically and how we can try and adapt the international recommendations to our local setting. I don't think there's any more important thing that we can actually look for actively these days to prevent progression to esophageal CA. And just as an introduction, please remember that despite recent advances in treatment options over the last sort of 10 to 20 years, esophageal adeno-CA still only, unfortunately, has a 20% 5-year survival. So just to remind you that this picking up Barrett's and dealing with it appropriately is probably the only time you can actually make a genuine difference in avoiding these terrible progressions. So I think Barrett's management tends to confuse people. It shouldn't really. We just really need to have a structured approach and what is clinically feasible in your local environment. So I think the 6 sort of important factors to look at, in my opinion, are screening. What are your surveillance options? What should we do as regards a biopsy protocol? Specifically, what to do with low-grade dysplasia? And then what should your endoscopic eradication therapy entail, specifically when looking at nodularity, high-grade dysplasia, and of course, if you're lucky enough to pick up an early adeno-CA. And then what should your post-endoscopic eradication therapy be as regards the surveillance of those patients? So firstly, I think the important question is, should we actually be screening at all? I think screening for Barrett's in the general population isn't recommended. It is, however, recommended if you are if you have a target population where there are multiple risk factors, of which chronicity of GORD, not severity, and family history are the most important. Granted, though, there are limitations to Barrett's screening, and I think the big one is that it's invasive and it's very costly, and in an environment at the moment where we're trying to reduce cost, that obviously becomes a big deal. But if you have a family history and long-standing reflux, by all means, I think you're justified in taking a look and seeing what's happening. So for South Africa, and perhaps also the rest of the continent, I suggest only to screen if there are 2 or more of the above risk factors that we mentioned. And the one thing that you can add into that, if there is a family history of Barrett's and or a family history of an esophageal adeno-CA. We should be pushing more and more for less expensive options as regards screening. Non-endoscopic screening would include transnasal esophagoscopy or a cytosponge. Now that, I think, is specifically for the African esophageal squamous belt along the eastern coastline, I would think is a very interesting option. It's been proven without a doubt as beneficial for the pickup of Barrett's dysplasia, but I think we should be investigating this for squamous carcinoma as well. Anyway, let's get back to Barrett's. I think you'll all appreciate and understand that there's much inter-observer variability as regards Barrett's histology. So please, please do not waste your pathologist's time when you are biopsying erosive esophagitis. It's very difficult to differentiate at the best of times. So I think it's quite reasonable if you get a patient with erosive esophagitis and you think there's some Barrett's as well, please treat for 6 weeks at least with double dose PPIs, then rescope your patient, and then only do your biopsies for your dysplasia evaluation. Also take note that it's worthwhile finding out in your pathology colleague group who has an interest in Barrett's, as the expert opinion consensus really much improves if you've got someone with an interest in Barrett's. It's a tricky one to accurately get right. So what do you do once you do find Barrett's? I think first of all, it's an essential habit to get into that you start describing and documenting your segments of Barrett's according to the Prague classification. And this has value for a couple of reasons. It's there for future comparisons, and it's also a good habit to maintain in that there's, as you all know, there's between us as endoscopists, there's a lot of variability. And I think looking at a report with an accurate assessment as regards Prague is essential. So start doing that. Remember how to do it properly. So you need to go down all the way to where you think the OG junction is. It's tricky to sometimes differentiate. So look for the gastric folds where they end. That is where your Barrett's is starting, and that is point 0. So that would be there, all right, or on the longitudinal picture on your side over there. Then you go up and you mark as your sea level the maximum height where the Barrett's is circumferential. So for example, in this case, it might be 3 centimeters. Then your M value would be where you get the maximal flame extending up the length of the esophagus. And for that might be 6 centimeters or whatever. So then it's C3M6. And that you document every time you go through the screening process with your patient. Now, as regards the biopsies, you do need a systematic approach. And please appreciate, if you want to do it properly, like colonoscopies, this is something that takes time. Not possible if you're doing an awake esophageal assessment. So I do think this is one time where you absolutely have to sedate your patient. Couple of things. First of all, your inspection time should take more than a minute, they say, per centimeter of Barrett's. Now that sounds short, but it feels quite long when you're actually there. And then I think all the authors will agree internationally that any abnormal or nodular area must be excised preferentially. And if you can't do that, biopsy it at least. If you are biopsying new Barrett's, then if it's a completely new patient to you, the standard of care is systematic random biopsies according to the Seattle protocol. And we'll get into that just now. If you're an expert, obviously, and you are able to perform accurate image-directed targeted biopsies with narrowband imaging or other forms of chromoendoscopy, well, that's recommended too. But I think for the majority of us, you must be aware of what is the standard of care, and that is Seattle. So let's look at Seattle, how to go about that. So if you have a new Barrett's, never been evaluated before, please do systematic 4-quadrant biopsies every 2 centimeters. And you start at 0. So you're starting at your OG junction where your Z line would have been. Remember that the lower segment of Barrett's is where your majority of your tumors and your dysplasia starts. So start at 0 and then you go up 4 quadrants every 2 centimeters. It's time consuming. It's also costly. And I think a lot of people don't adhere correctly to that. If it's a short segment, you can get away with sort of 8 random biopsies. But once it's more than 4 centimeters long, it's absolutely essential to follow the Seattle protocol. One difference, if this is a patient that is known with dysplastic Barrett's, then unfortunately your work increases. And if you are unable to do targeted biopsies, then your random biopsies according to the Seattle protocol are now 4 quadrants every 1 centimeter. And that is, just as a reminder, only if you have previous biopsies indicating dysplasia. Now, what about my surveillance? I think this is something that we often get referred back and back unnecessarily. If you have intestinal metaplasia, meaning non-dysplastic Barrett's, you do not need to biopsy it every 6 months. It's 3 yearly if the segment is longer than 3 centimeters, and increases in time to 5 yearly if it's a short segment, so meaning less than 3 centimeters. So I think that's a big thing. As soon as someone sees Barrett's, they refer back for 6 monthly scopes. It is unnecessary if it's only intestinal metaplasia. So that's, I think, is one important thing to remember. So what are our non-endoscopic treatment options? I think the first thing to appreciate, which some of us might forget every now and then, is that PPIs, the half-life does not cover 24 hours. So if you've got Barrett's, my recommendation to you is to split the dose. So give it as a 12-hourly dose. What PPI you use, I think that's up to you, or what specifically is available in your hospital. The other sort of non-endoscopic options, specifically aspirin, the NSAIDs, and also your statins, the jury remains out. There does seem to be a little bit of regression, or at least decrease in progression, but for the moment, they are not recommended as a standard chemopreventative agent for Barrett's. So it's just something to know about. We'll see where that goes. But the only thing that absolutely is essential and works is a PPI, and you're going to give that twice daily. Fundoplication. A couple of things here. Surgical prevention of progression of Barrett's is not a given. So I think please to remember that you should be referring your patient with Barrett's for fundoplication only according to the Icarus guidelines. So if you have an asymptomatic Barrett's, do not offer anti-reflux surgery. Barrett's itself is obviously not a contraindication to eligible patients, but those persons you are offering anti-reflux surgery to should still fulfill the Icarus guidelines as per usual. Then the other very important thing is that once you've done a fundoplication, your Barrett's is not necessarily going to regress or disappear. And your post-op surveillance absolutely has to continue as per your Barrett's dysplasia grade. So it's not a patient you can now forget about because you've had a fundoplication done. And I've got an unfortunate situation now, in fact, with a patient that was quite convinced his fundoplication sorted out the Barrett's. He's now got a malignancy. And he didn't disclose that he had Barrett's to his medical insurance, and they're now refusing to cover his chemo and his surgery. I mean, it's really a mess. So it's really something you have to continue your surveillance with. Now, how do you do your endoscopic surveillance? Again, it depends very much on how comfortable you are with it and what scope equipment you have available to you. I think most of us will have a very good white light high definition scope these days available. Narrowband imaging of some description is on all of the newer scopes, and I think the big thing there is to actually get used to it. You've got such a long list and you just fly through the list. Switch on your NBI sometimes when it's normal, just to appreciate what is normal, so that you start picking up the irregularities, the vascular malformations, all of those things on NBI as you go along with your endoscopic experience. I'm not sure if anyone's got Zoom available on their scopes. I think that's awesome. I would love that, but that's not something we have. The other addition that you can offer to your improvement of pickup is obviously the cheapest option, in my opinion, is dilute acetic acid. And when you apply it, it leads initially to a whitening of the Barretts. And then the dysplastic Barretts, the whiteness fades first. And then you get this red patch, which I hope you can appreciate there. This indicates where you should be targeting your biopsies of that patch of Barrett's. So where it still remains whitish, that is probably non-dysplastic. This reddish area is where you should target your biopsies once you've seen that whitening disappear following the application of the diluted acetic acid. So that's quite a useful technique. And I think you should, yeah, if you don't have the capabilities to do anything else, that's something you can definitely do very cheap. Now, endoscopic eradication therapy, let's talk about specifically now for low-grade dysplasia. You've got essentially two options. The one is quite clearly surveillance, and you perform your surveillance scope every 6 months. The other option is to ablate it, so endoscopic eradication therapy. There's enough evidence, in my opinion, especially following the SURF trial, that you should be ablating low-grade dysplasia. I think it's only fair to consider to continue with surveillance if you do not have any ablation options available to you. So what would ablation entail? So there's various techniques that are available, cryotherapy, argon, and others, but I think most of you will be aware that radiofrequency ablation is the most commonly used. It's also the most researched with the best outcomes, and it's also what we're able to use locally. Cryotherapy possibly still has a place, specifically in recurrent or refractory Barrett's, following prior RFA. So I think there's some evidence that cryotherapy is possibly something to keep in your back pocket. We don't have that, but the international expert centers definitely do that. The cryotherapy also apparently offers less pain post-procedure, less strictures, but I think ultimately we need to await a randomized trial between cryotherapy and RFA. I'm going to take you through RFA. We are quite comfortable doing that here. I think firstly, the big thing to appreciate is it's jolly expensive. It really is a pricey thing to do, unfortunately. The second thing is your patient needs to be aware that is often not a once-off. You may well have to do this 2 or 3 times, unfortunately. And each time it's quite an expense. What you see on these images here is a focal ablation, and we are using a through-the-scope radiofrequency ablation catheter. The active blade is the gold plate that you see here. And then the idea is that you approximate nicely against the mucosa. There's a foot pedal that you step on. It's a predetermined amount of energy that is applied. You don't have to work it out. And the time it is applied for is also predetermined by the equipment. So it's fantastic. It's really quite easy to do. And all you do is you move your plate along the Barrett's that is visible. It's also very, very nicely rotatable. It's much easier than actually the clips. It's a nice device to use. Then if you have a long segment, so anything I think sort of more than 3 centimeters, I wouldn't waste my time with a through the scope device. I would go for the self-sizing balloon. And what I'm trying to show you there on the picture is that it's a balloon with a 4 centimeter application surface that expands as the balloon self-sizes and gets feedback from the pressure from the mucosal wall. It'll stop automatically. It's great. And then again, you step on the foot pedal, the device applies the ablation energy predetermined for a predetermined time. And then I hope you can appreciate here, you get this beautiful 4 centimeter circumferential segment of ablation to your Barrett's. What you need to do once you've done that is come out, take out your device, and you're left with a sort of friable, burnt mucosa. You then apply a slightly beveled plastic cap to the tip of your scope. And with that, you go down and you basically scratch away this friable dead tissue. And then you're left with a sort of reddish, oozy looking mucosa. And then you are going to go back down and apply a second dose of radiofrequency ablation. And if you do that, and that is sort of regarded as the standard, you should get a regression rate of up to 85% of your Barrett's. The other options are that you double ablate. Basically, if you're lazy, you don't feel like cleaning, you ablate and then ablate again. The problem with that is you get a higher stenosis rate, specifically if you're doing a circumferential burn. And then if you're even lazier than that and you do a single ablation, you only get back a regression rate of 73%. So I do think it's such an expensive procedure. Do it properly, burn it, clean it off, and then ablate it again. It really is an effort. Just for interest's sake, I'm not sure the rest of the continent, but here in South Africa, the 360-degree radiofrequency balloon presently, I think, costs about 32,000 Rand. And the through the scope one is sitting at about 27,000 Rand. So it's crazy expensive. Do it properly first time round. Now, what side effects or risks can you expect after a radiofrequency ablation? Definitely warn your patient that they might have some chest pain, chest discomfort. Not everybody, sort of a quarter to a half of them, and it's usually quite mild, but it does sit there for a few days. Strictures are more likely, obviously, in the circumferential burns that you're doing. Very seldom do you get a significant bleed. It's usually a bit of a ooze after you've scraped off that second layer, that burnt layer. And the risk of perforation is genuinely very, very small. You only increase that if you are doing an endoscopic mucosal resection at the same time. I've had one very unusual complication in that I had a patient that came back a day or two after his circumferential burn, quite septic, and on swallow, I obviously thought I had perforated. There wasn't a leak or anything, but on blood culture, there was an E. coli grown on the culture, blood culture. So that was a bit weird. It obviously had to do somehow with my ablation. They must, I don't know, microperf, or I still don't know. But that was a weird one. Most of the time, it's just chest pain, which resolves in due course. So, just in summary, what about outcomes as regards the ablation? Radiofrequency specifically I'm speaking about. You get a good complete eradication in the majority of patients, up to sort of 90%. And as I said before, it's often that you will need more than one session. In addition, the progression to high-grade dysplasia or even adeno-CA is decreased by a quarter over a 3-year period. So that's definitely worthwhile. For our practices, we bring back the patients at 6 to 8 weeks after their initial ablation, and then are prepared with the equipment ready for a repeat ablation if there's any evidence of the Barrett still present. And your ideal is to go until you've only got intestinal metaplasia left or nothing visible. Most unfortunately, though, you do need to warn your patient that their recurrence rate does sit at 2 years up to a third. So it really is something that you continue almost lifelong. So don't get rid of your patient entirely if they are having an initial good response. Now, let's talk a little bit about your endoscopic eradication therapy, specifically when you have confirmed high-grade dysplasia or a nodular Barrett's, or even if you have a confirmed T1 in situ. So for any visible lesions, elevated lesions, either nodular or mucosal irregularity, or if you've had a prior biopsy confirming a T1 in situ or a high-grade dysplasia, you should be removing that in a segment by endoscopic resection. it is only recommended to ablate residual flat Barrett's. So I hope you can appreciate these are three different, actually it's two the same and one different patient, where there's quite obviously a nodularity peaking up from the rest of the flat Barrett's. So that's something you need to take out. The question then comes is, what is better, endoscopic mucosal resection or endoscopic submucosal dissection? Now, there's pros and cons to each. Similar outcomes, fortunately, despite the slightly higher chance of recurrence in an EMR, it's not significant and doesn't luckily translate into poorer long-term outcomes when compared to ESD. It's not statistically significant. So just remember, similar long-term outcomes, and you should be doing what you are comfortable with. The big difference is obviously the time it takes to do and the skill that's required to do an ESD. Interestingly, though, the perforation rates, delayed bleeding, and stricture rates are reportedly quite similar between the two. I still find that a bit surprising because I've definitely perforated more ESDs than EMRs. And I find a large ESD quite challenging, whereas an EMR is generally quite a non-stressful procedure to perform. Let's talk quickly about EMR. I think there's a few technique variations that are available, but I think a standard snare and a lift with a cap technique or even a multi-band mucosectomy is pretty much the way to go. If you have varicose banders, that's absolutely fine. Use that. You do not need to order the special mucosectomy banders. It's exactly the same thing, just a different, more expensive box. So use your varicose banders. One thing I think that is contentious, if you have a lesion that you're a little bit worried about as to depth and you want to check whether it actually lifts, please by all means inject some methylene blue saline underneath it, and if it lifts beautifully, fantastic, then you can go ahead and quite safely do your EMR. The one thing that lifting does do, because there's now this pillow of liquid under your piece of mucosa that you want to resect, the ability to suck your mucosa into your cap is a bit decreased, and you actually get a smaller piece of mucosa out. So if you're quite convinced and you don't need to lift, then I don't inject. The alternative is what you're seeing here. We inject and then let it dissipate sort of over the next 5 to 10 minutes, then go back when it's flat and then put your band on. Because then you get a good couple of extra millimeters circumferentially as you suck that mucosa into your cap. The benefit of submucosal lift, I really enjoy it. I find it hugely useful. And the basics is quite simple. If it doesn't lift, you know there's obvious deeper infiltration. You don't need an EUS then to confirm this. And I must also confess, even if someone's helping me, I really struggle to define the esophageal layers nicely on EUS. So I rely quite heavily on a good lift. And what you can see here is that same nodularity we had in a previous picture. I did lift this here, so that's why it's stained a little bit blue, but you can see that that's come out quite nicely. There's no concerns for a deeper mucosal injury. The other thing to do when you put your snare around your little polyp, your band that you've created there, just make sure once you've tightened your snare that you can wiggle your snare quite freely. If it doesn't wiggle nicely, you've potentially caught some underlying muscle fibers. So then readjust your polyp snare. Just a brief word about EUS in Barrett's. I think it is considered a standard modality for the evaluation of early lesions, early T1As, obviously as well as regional lymphadenopathy. But I think for Barrett's, for flat Barrett's, it's less useful. It's also less accurate. So I think for flat Barrett's, I wouldn't even ask anyone to get out the EUS scope. And also, it's, as you all know, it's very much a time-dependent expertise requiring intervention, and we don't all have that available. The radial EUS works better for a circumferential appreciation. We used to have that. I found that easier to interpret than the linear EUS. But fortunately, I've got some colleagues who are more adept at that than I am. Your ESD, so that's one layer deeper, and you're going into the submucosal space. The big thing is, once you've found a nodularity within your Barrett's, it's always best to define it by burning a little spot around it, and then once it's taken out, spread it out, pin it down. You can see another different patient here, another nodularity on the proximal margin of a Barrett's, also taken out there. The blue again is because I've lifted it with methylene blue. I quite like the methylene blue. You don't have to do that. You can use plain saline or whatever, or colloid, but the methylene blue to me makes I use it for the POEMS procedures as well, and it makes the muscles much more dominantly white, and I just like that safety factor of the white muscles as a visibility thing. So I use methylene blue. A couple of words about T1A versus T1B. I think that's important for those early lesions within a Barrett's that have now become a proper cancer. I think the endoscopy resection depth versus outcomes is much better understood if you remember back to your anatomy where the watershed area is as regards the lymphatics. Remember that an adeno-CA in situ sits in the mucosa. Well, that's not a problem. But once it goes down through into the submucosa, remember that your watershed where the lymphatics is at roughly at the bottom third, deeper levels of the submucosa. So early adeno-CAs that involve the mucosa only, so that's T1As, really have a very high, a very low risk for lymph node mets. And the literature reports that as being less than 2%. So your endoscopic therapy would probably be completely curative in this situation. Once they go a bit deeper into the superficial submucosa, you can probably also manage them endoscopically. There's emerging evidence that it's quite safe to do so. But I would like you for this to divide in your head the submucosal space into 3. And remember that for an adeno-CA, if the tumor invades your superficial third of your submucosa, specifically for a depth of less than 500 microns, and in addition is well differentiated, and there's no evidence on your biopsy specimen that there was lymphovascular infiltration, then the lymph node risk of, the spread, let me rephrase that, the risk of lymph node spread is also quite low, so at about 16%. So if you have a frail patient and an esophagectomy or chemoradiation is a big deal, you can define what is a good prognosis T1B lesion. Remember, less than 500 microns. And then you can probably say that this is a patient safe to do an endoscopic eradication therapy on. So I like this. Saunders et al., they put it quite elegantly. I think, and I agree with the statement, they said that an endoscopic resection for an early esophageal adeno-CA can be justified if the rate of coexisting lymph node mets is less than the mortality rate from your esophagectomy. So that makes quite sense to me. I think that's very useful. I know we're not talking about squamous cell, but just one word of caution as regards the squamous cell early tumors. remember they have a higher likelihood of nodal spread. And as such, the depth of infiltration acceptable where you can safely offer an endoscopic treatment is a bit more superficial into your submucosa, and it should be not more than 200 microns. So that's a bit different. So just remember that for your squames. So what factors do we know are associated with a higher recurrence post-endoscopic eradication? So quite clearly, as for any tumor, once you've got lymphovascular invasion, there's a problem. T1B, submucosal involvement, that's quite clearly an issue. But we mentioned, if it's less than 500 microns for an adeno, you should be okay. And if it's less than 200 microns for a squame, you might still be justified in managing endoscopically. Purely by histological concerns, squamous cell carcinoma is obviously more recurrent. You don't need to know much more than that for squames for now. Deeper lesions, obviously, and anything where you've taken out piecemeal resections, not an oncological ESD resection, there is the theoretical risk for recurrence. And then definitely lesions more than 20 millimeters in diameter, they unfortunately clearly have a higher recurrence rate. What about your surveillance after your successful endoscopic eradication treatment? Yes, please do so. It's recommended. Absolutely. Don't forget about the patient. So remember that most recurrence are likely to occur within the first year. And most of these will be concentrated to the distal 2 centimeters of the esophagus of your Barrett segment, or the lower 20% of your original Barrett's. So if you are doing random biopsy sampling, it's unnecessary to do it of the whole original Barrett's zone, and you should focus rather on the distal 2 centimeters. It's also quite clear that most late recurrences are usually endoscopically visible, and we could luckily pick them up. But if you don't know where to biopsy, that's fine. Biopsy the distal 2 centimeters. So this is a surveillance protocol recommended. And as we said, your biopsy protocol should be limited quite clearly to, if you can't see anything, then you distal 2 centimeters. Don't forget to also biopsy your cardia. And obviously, as we said, any visible lesions. So to conclude, if you're just doing a surveillance biopsy protocol post-successful treatment, you should be ending up routinely with 12 biopsies regardless. Cotton et al., they indicated that the probability of recurrence of intestinal metaplasia is highest in the initial 2 years. And luckily, there doesn't seem to be much recurrence after 4 to 5 years. So it's probably quite safe to say that you should be surveilling quite intensively as per the protocol for the first 2 years. And then you can tell your patient after 5 years, you should hopefully be lucky, but not to forget about them from year 2 to year 5. You should definitely still be seeing them. What do you do specifically for high-grade or early adeno-CAs that you've taken out successfully and completely? Please see them intensely in the first year, so every 3 months, then 6 monthly in the second year, and after that you can go back to an annual surveillance. The dysplastic Barrett's recurrence is about 2%, and for high-grade or adeno-CA, 1.2% per patient year. And as we said, fortunately, the vast majority of recurrences will be endoscopically visible, and most will be treated successfully endoscopically the second time around again. Now, what about surgery as an adjunct to endoscopic therapy? I think it's something just to be aware of. For T1 esophageal cancers staged by EMR or ESD, surgery is reserved where there's a high risk of lymph node metastases. So that, according to guidelines, is where your submucosal invasion is an indication for definitive surgery, except, remember, where we said good prognosis ones are where the infiltration is less than 500 microns. And you should ask that your pathologist don't just report submucosal, they actually need to report to you depth. And then your specimen, your pathology report comes back, for example, T1A M3 or T1B SM1. So they need to define those 3 layers. Divide your submucosa into 3. If they can do that, that's great. Makes it quite easy for you then to decide whether you're offering surgery or not. Esophagectomy can also be offered to inoperable patients with esophageal lesions that cannot be lifted during an EMR or dissected out by an ESD. And remember also that an esophageal resection is a possible rescue therapy for recurrences or metachronous neoplasia, where you've tried or you've ended up at the end of your limits as regards endoscopic therapies that you can safely offer. And bottom line is 9 to 28% of endoscopically treated patients, so almost 20% on average, will end up at some point needing an esophagectomy, unfortunately. So yeah, something to chat to your patients about from the start. I think they need to be aware that this is potentially in some of them the way it's going to go. So to summarize on one slide, what should your approach be to Barrett's as an overview? If you have intestinal metaplasia confirmed and it's short segment, rescope 3 to 5 yearly. If it's more than 3 centimeters, rescope 3 yearly. If you have an indefinite biopsy result for dysplasia, go back in 6 months. You need an answer because you need to know where to put your patient as regards this algorithm. So go back until you have a definitive answer from your pathologist. Low-grade dysplasia. Your options are to repeat in 6 months and continue so. If you are working in private practice in South Africa, the unfortunate thing is that you will need 2 biopsies 6 months apart, both confirming low-grade dysplasia, before the medical aids will actually fund and authorize a radiofrequency ablation. So for that reason, we need 2 biopsies 6 months apart. If you have that confirmed low-grade dysplasia, as I said, your options are intensive surveillance every 6 months. I don't agree with that. I would go straight and offer a definitive radiofrequency ablation procedure, bearing in mind you and your patient should be aware that this may well have to be done a couple of times. If you have, on the other hand, a nodule or a high-grade dysplasia confirmed, or even a T1A, or nowadays a good T1B carcinoma, you should be offering an endoscopic resection. Whether you offer an EMR or ESD depends very much on your local availability of skills and what you're comfortable with. And then not to forget, you have to follow these patients up. You cannot just forget about them. These things do come back. And then to remember, of course, you have the option of a salvage esophagectomy. You still have a patient with a very early carcinoma. If you cannot manage it endoscopically, there is still potentially a very good prognosis. So that's my story for today. I hope that that's sort of cleared a few things for you, and I'm happy to answer any questions. Let's just see. I think there were some things in the chat. Let's open that up. Yeah. So somebody is asking about whether there's a recording. There is. It's available on the Gastro Foundation website, so please take a look at that. If I spoke too quickly or made a mess of things, go back and look at the slides. Yes, we've got somebody who raised their hand. Please, you're welcome to give me a shout. What can I help you with? What's your question?
Hi, thank you for a great presentation. I missed some of it. Could you please put in perspective acetic acid chrome endoscopy? Would we do that routinely when you see a patient with Barrett's after you've diagnosed them, or should we just reserve it for those patients where we've diagnosed them with adeno-CA.
Okay, thanks for the question. So I think acetic acid is a very useful addition to your approach when you are trying to target biopsy something. I don't think it's absolutely necessary as a routine, as a first up. So if I get I don't know, let's say a 4-centimeter segment of Barrett's, and it's the very, very first time that this patient is presenting, my approach would always be to do a proper Seattle biopsy protocol. So every 2 centimeters, 4 quadrants. And then I have an idea of where I am at from the start with this patient. I think bringing the patient back after that, where you've got confirmed low grade or you've just got flat intestinal metaplasia, then I would start considering the acetic acid as a targeting agent to help me focus my biopsies. Specifically useful when you've got a long segment, and you really, I mean, as you know, if there's any dysplasia, we just mentioned, you should be biopsying every 4 quadrants, every centimeter, and that's quite labor intensive. So if you have the capability to offer acetic acid to pop up the areas that are potentially more dysplastic, by all means, do it then. But my recommendation to you is, as a first presentation with Barrett's, do the Seattle biopsies properly first time around. If you're an absolute expert in this, they will then progress straight to targeted biopsies. But I think for most of us, Seattle is the first step and the safest step to do. I hope that answers your question.
Okay. No, thank you very much. I've got one last question.
Yes.
And it's about the anti-reflux endoscopic mucosectomies. Is anyone doing them in the country or?
Not that I'm aware of. Do you know of anybody? No. No, not that I'm aware of.
Okay.
Okay. Have we answered everybody?
Bashiko's got
Sorry?
Galya, there you go.
Mashiko, sorry, I didn't see you. Yes, go ahead.
No worries. Thank you. That was an excellent talk on this topic, which can be very confusing, but I thought it was absolutely clear. Brilliant. I thoroughly enjoyed it. My question is relating to age. So given the rate of progression from Barrett's to adenocarcinoma, do you differentiate an 80-year-old man who, the one has got very good performance status, I mean, is a very good 80, gets on with his life. The other one, say, has comorbidities, etc., and both are amenable to endoscopic treatment. Does it matter to you, or then you would do both of them and treat them endoscopically, or the one who's not a great 80-year-old, you may leave it alone and just leave him on BD-PPI? At which point do you stop, surveilling, treating? Does advanced age come into it at all, especially if it's going to be endoscopically amenable to therapy? Thanks.
Mashiko, I don't know if there's any recommendations in the literature as regard age. I would think not, because I think I think it's very much a clinical impression that you've got on the day when that patient is sitting in front of you. And I think I 100% agree with you. If I've got a very frail, dodgy looking 80-year-old on warfarin in CCF, what am I doing? Surveilling. I would stop all of that. And the rate of progression is so slow that I'm sure her comorbidities would get her before the Barrett's progresses to something else. And in that case, I would absolutely advocate for just routine double dose PPIs and leave it at that. I think that's reasonable, honestly.
Yeah. Okay, thanks. Thanks, Galya.
Okay, I think I don't see any more hands up. Yeah, so I think let's call it a day. And then it just remains for me to thank everybody from Echo UNM and the Echo India team. And as we said just now, remember that the recordings of these talks for the whole year are available on the Gastro Foundation website. You're most welcome to catch up there. And then, of course, thank you to the Gastro Foundation and to Cheryl and Karen. And we hope to see you next week. The topic is one of the pediatrics topics. And yeah, again, thanks to the sponsors and enjoy the rest of your evening. Bye-bye.